Welcome to the Explainer. Today, we are diving deep into a super high-yield topic for your board exams, hemochromatosis. We're going to break down everything you need to know, from the genetics all the way to the simple, life-saving treatment.
All right, let's jump right in with a classic buzzword you'll definitely see on a test: bronze diabetes. When you see that phrase, your brain should immediately lock onto one diagnosis: hemochromatosis. This isn't something that happens overnight. It's a genetic disorder where iron slowly, silently builds up in the body over years.
So, to really get what's going on with hemochromatosis, we have to start at the very beginning, at the molecular level. It all boils down to the genes that are supposed to be controlling how our bodies handle iron.
Here is the absolute key takeaway. This is an inherited autosomal recessive condition. So what does that really mean? It means the body's internal thermostat for iron is just completely broken. It can't tell when it has enough, so the gut just keeps absorbing more and more iron from the food you eat. Okay, if you're going to memorize one gene for your exam, this is it, the HFE gene on chromosome 6. You could think of it as the body's master iron sensor. The specific variant they love to test is C282Y, so if a patient is homozygous, meaning they got a faulty copy from both parents, they are at the highest risk of developing the full-blown disease. So here's how it all connects. That faulty HFE gene, it causes the liver to produce way less of a hormone called hepcidin, and hepcidin is the gatekeeper. It's supposed to tell your gut when to stop absorbing iron. With low hepcidin, that gate is stuck wide open, 24/7. The gut just keeps pulling in iron day after day, year after year.
All right, let's move out of the textbook and into the clinic. What does this genetic problem actually look like in a patient? Well, that iron slowly builds up in organs all over the body. And the early signs, well, they can be really subtle. Early on, a patient might just complain about feeling tired or having some joint pain. I mean, who doesn't feel like that sometimes? It's so easy to miss. But as that iron continues to pile up, you start to see that classic, devastating end organ damage. We're talking cirrhosis from iron in the liver, that famous bronze skin, diabetes from damage to the pancreas, heart failure, and hypogonadism.
And the consequences of leaving this untreated are just severe. Patients who develop cirrhosis have a really high risk, like 15 to 20% of getting hepatocellular carcinoma, which is liver cancer. And here is another fantastic, super testable fact. All that extra iron makes the body a perfect breeding ground for certain bacteria, iron-loving bugs like Vibrio, Listeria, and Yersinia.
So you're in the clinic, you suspect this might be going on. How do you actually prove it? Thankfully, the diagnosis follows a very clear step-by-step process using specific lab tests. The diagnostic path here is just pure logic. It all starts with a clinical suspicion, right? Maybe a family member has it. From there, you order some simple blood tests. If those come back abnormal, you move on to the genetic test to confirm it. And then finally, once you know for sure it's hemochromatosis, you have to figure out how much damage has already been done, especially to the liver.
Okay, your first screening test is always going to be iron studies. And the single most important initial marker, the one that will be high first, is the transferrin saturation. This basically tells you how much iron is currently hitching a ride on its transport protein in the blood.
You have to burn this number into your brain for the exam, a fasting transferrin saturation over 45%. That is your trigger. That's the red flag. It is highly suggestive of iron overload and means you absolutely have to keep investigating.
All right, next up, you look at the serum ferritin. If transferrin saturation tells you about the iron that's on the move, ferritin tells you about the body's total iron savings account, all the iron that's been squirreled away in the liver and other tissues.
So, a high ferritin level confirms the iron overload. Just remember these general thresholds: over 300 for men and postmenopausal women, and over 200 for premenopausal women. But here's a really crucial point. When that ferritin level gets above 1,000, that's when the risk of cirrhosis goes way up.
So, we've got our diagnoses. Now what do we do? What's the plan? Well, the great news is the treatment is surprisingly simple and incredibly effective. But it's a lifelong commitment.
The number one, first-line, gold standard treatment for hemochromatosis is regular phlebotomy. Yep, it's that simple. It's a highly effective way to physically remove iron from the body just by taking out red blood cells.
So, the treatment protocol has two parts. You start with an aggressive initial phase. We're talking weekly phlebotomy to get those iron stores way down to a safe level. We're aiming for a ferritin between 50 and 100.
Then, once you hit that target, the patient moves into a lifelong maintenance phase, coming in for a phlebotomy every few months to make sure that iron never builds back up.
Now, while phlebotomy is the absolute standard of care, you should know that there is a backup plan. For patients who just can't tolerate it, maybe they have severe anemia or just poor veins, there are medications called iron chelators. These drugs basically grab onto the iron and help the body get rid of it, but they're definitely considered second line.
This is so important to understand for counseling patients. Treatment can dramatically improve survival and can even reverse some early liver fibrosis and heart problems. But, and this is a big but, some of the damage is permanent. The arthritis, the diabetes, and certainly established cirrhosis, those things are often irreversible, even after you get all the iron out.
So, after all of that, from the HFE gene all the way to the phlebotomy schedule, what is the single most important bottom line message you should take away from this whole explainer?
It really all comes down to this: catching the disease before irreversible organ damage happens. That means screening at-risk family members and paying attention to those iron studies. And once you have the diagnosis, it's all about committing to that simple, life-saving, and lifelong therapy of phlebotomy. That is the key to preventing the absolute worst complications of this disease.